Hello, everyone. Good morning, good afternoon, good evening, wherever you're joining us from, and welcome officially to the ninth session of the International Deprescribing Journal Club, hosted by the Network of European Researchers in Deprescribing, or NERD. This journal club is the product of a collaboration between the Australian Deprescribing Network, the US Deprescribing Research Network, the Network of European Researchers in Deprescribing, the European Society of Clinical Pharmacy, and the Canadian Medication Appropriateness and Deprescribing Network. To start, we do want to thank all of these groups for their efforts in collaborating with us to plan this session. To introduce myself, my name is Frank Moriarty. I'm an associate professor at the School of Pharmacy and Biomolecular Sciences, based at RCSI University of Medicine and Health Sciences in Dublin, Ireland. I'm also our institutional lead for open research. A bit of housekeeping just before we get started. To help us ensure good audio quality during the speaker's presentation, please do keep your microphone muted. Because not everyone is able to attend live, especially since we're living in different time zones, we will be recording this session. Please take note that this recording will be posted on the CADeN YouTube channel later today. The information on the recording will be posted on deprescribingnetwork.ca/journal club. You can also consult this webpage to view all previous Journal Club sessions. I'm delighted to introduce our speaker for today's Journal Club session. Katharina Jungo is a postdoctoral research fellow at the Center for Healthcare Delivery Sciences and Division of Pharmacoepidemiology and Pharmacoeconomics at the Brigham and Women's Hospital and Harvard Medical School. Her research interests include the use of high-risk medications in older adults and patients with chronic conditions, novel digital health interventions to optimize prescribing practices, and patient-centered approaches to deprescribing. So without further ado, Katharina, I'm going to hand over to you, and if you'd like to share your slides and go off whenever you can.
Thank you so much for this kind introduction. Good morning, good afternoon, good evening. Thank you all for being here. I would like to thank the organizers for inviting me to talk today. I'm excited to be here and to share the results of a clinical trial and different sub-studies that I worked on at my previous institution, the University of Bern in Switzerland. I'm going to talk about the lessons learned from a trial in which we tested a structured medication review intervention in Swiss primary care settings. I will first present to you the OPTICA trial and talk about the effectiveness results, then talk about the implementation evaluation, and finally, we will discuss the cost-effectiveness part of the study. The OPTICA trial was a cluster randomized control trial conducted in Swiss primary care settings by an interdisciplinary study team. It was led by the PI, Dr. Sven Schreit, at the Institute of Primary Healthcare of the University of Bern. There were project partners at different Swiss universities and also at Utrecht University in the Netherlands. The OPTICA trial was a cluster randomized control trial conducted with general practitioners and adults aged 65 years and over with multimorbidity and polypharmacy. In the study protocol, there were 3 pre-specified components. The first one was to assess the effectiveness of a structured medication review intervention centered around an electronic clinical decision support system. The second one was to evaluate the cost-effectiveness of the study intervention. And the third was to conduct an implementation evaluation to better understand what happens in the intervention group during the trial. The main research question behind the OPTICA trial was, can the use of a medication review intervention centered around an electronic clinical decision support system help improve medication appropriateness and reduce prescribing omissions in older adults with multimorbidity and polypharmacy? we recruited study participants, the GPs, first, up until the end of 2018. In early 2019, the GPs began recruiting patients among their patient cohorts, and patient recruited ended in February 2020. As you can remember what happened in 2020, I was so glad that we finished patient recruitment before March 2020. And you can imagine how different things could have been if this would not have been the case. All the patients were followed up for 12 months, and the last patients finished their 1-year follow-up in February 2021. On this map, you can see the locations of the GP practices of the GPs that we recruited for the study in the Swiss German-speaking part of Switzerland. Switzerland has 4 national languages, so for feasibility reasons, we stuck to the Swiss German-speaking part. The 2 photos that you can see on the right-hand side of the slide were taken during one of our many recruitment visits to GP practices. So throughout 2018, my colleagues and I, we visited each and one of the GPs. I think we had contacted more than 100 and then visited around 60 in their practices to present the study, to address their concerns, answer their questions, and make sure that the practice management systems would allow data exports throughout the study. All the study participants were older adults aged 65 years and over, and they had to be a patient of one of the participating GPs. All of them had multimorbidity, which in this study was defined as 3 or more chronic conditions. And all of them had polypharmacy, which was defined as 5 or more medications. We deliberately chose few exclusion criteria to maximize generalizability. So this meant that patients with cognitive impairment could be included through proxy consent. In the OPTICA trial, there was a 1-to-1 cluster randomization at the level of the GP. In the control group, there was a medication discussion in line with usual care between patients and GPs. In the intervention group, there was a structured medication review intervention performed by GPs with their patients. And this medication review intervention was centered around the use of an electronic clinical decision support system. The electronic clinical decision support system tested in the OPTICA trial was called Systematic Tool to Reduce Inappropriate Prescribing, or short, Strip Assistant. It was developed by our colleagues in the Netherlands at Utrecht University. And it was based on the second version of the stop-start criterion. On the left-hand side of the slide, you can see how it looked like. So if you had been one of the participating GPs, this is what you would have seen during the intervention. The Strip Assistant is the same decision support system as the one that was tested in the OPRAM trial that many of you likely came across in the past. You can think of OPTICA as a primary care spin-off of the OPRAM trial, which meant that for the OPTICA trial, we had to adapt the Strip Assistant for Swiss primary care settings. The Strip Assistant has the advantage that it can handle large amounts of clinical information, that it generates patient-specific prescribing recommendations, and that those recommendations go beyond detecting drug-drug or drug-disease interactions. The medication review intervention in OPTICA had 6 different steps. It started with me importing data obtained from the electronic health records in the participating GP practices through the FIRE project, which is a Swiss database collecting electronic health records from primary care practices into the Strip Assistant. And the information that we got through the FIRE database was information on medications, diagnosis, lab values, and vital data. In the second step, GPs had the opportunity to update and complete the information. In step number 3, they used the drag-drop function to connect each medication to a diagnosis, which was necessary so that in step number 4, the Strip Assistant ran the analysis and generated patient-specific prescribing recommendations. And such recommendations were, for example, recommendations to stop or start a medication or to adapt the dosage. In the next step, the GPs reviewed the recommendations that were generated by the tool and decided which ones they wanted to discuss with their patients. And finally, in the last step, they performed a shared decision-making process with their patients. Throughout the trial, we collected data from different sources, at baseline, 6 months, and at 12 months. On the one hand, there were phone calls with patients or relatives, in case of patients with cognitive impairment. During these phone calls, we collected information, for example, on falls and fractures, quality of life, and health services use. In parallel, we collected data from the electronic health records in the participating GP practices through the FHIR database. And again, this information was information on medications, diagnosis, lab values, and vital data. Throughout the study, we collected information on adverse events and serious adverse events directly from the GPs. And relatively towards the end of the trial, we collected quantitative and qualitative data on intervention implementation. There were 2 primary outcome measures in OPTICA to capture over and under prescribing. Both of them were measured at 12 months. Medication appropriateness was measured with the Medication Appropriateness Index, and this assessment was done for every chronic medication. The number of prescribing omissions was evaluated using the assessment of underutilization, and this assessment was done for every chronic condition. The secondary outcomes included drug-related outcomes, such as the number of long-term medications, the primary outcomes measured at 6 months instead of 12, patient-reported outcome measures that we had thanks to the phone calls with patients and relatives, falls, fractures, and quality of life, and the safety outcomes, such as death, the number of emergency room visits, and the number of unplanned hospitalizations. In close collaboration with the Clinical Trials Unit at the University of Bern, we had pre-specified the statistical analysis in a statistical analysis plan. In the main analysis, generalized estimating equation models were used, and both primary outcomes were tested separately. Success would have been claimed if either one of them would have been positive. Because of the missing data for our primary outcomes, which was between 13 and 18%, we used multiple imputation by chained equations to impute missing values in primary outcomes. We performed both intention to treat and per protocol analysis, and also did a set of sensitivity and subgroup analysis. We successfully managed to recruit the target sample size, so we would have needed minimum 40 GP clusters, and in the end we had 43 of them, each GP representing a cluster. And the GPs recruited among their patients based on screening lists of eligible patients that we provided to them based on the data from their electronic health records. In the end, there were 323 patients enrolled in the trial. In the intervention group, there were 21 GPs and 160 patients. And in the control group, there were 22 GPs and 163 patients. On this slide, you can see a selection of baseline characteristics at baseline. And overall, you can see that they were pretty comparable between the control and the intervention group. What stood out was that there was an imbalance at baseline in medication appropriateness, as highlighted by the red box. There was a higher level of medication inappropriateness in the intervention group compared to the control group at baseline. The main findings showed that we did not find evidence that the structured medication review intervention led to an improvement in medication appropriateness or a reduction of prescribing omissions. We also did not find evidence for a difference in any of the secondary outcomes. For example, the primary outcomes at 6 months, falls, or fractures. We did not find a difference in safety outcomes at the 12 months follow-up, but it was interesting that at the 6 months follow-up, there were fewer emergency room visits and fewer unplanned hospitalizations in the intervention group. Let's have a look at the implementation evaluation of the medication review intervention. As pointed out before, we collected both qualitative and quantitative information to better understand the implementation of the study intervention. We asked all the GPs in the intervention group to report information on how they conducted the intervention with each of their patients. Unfortunately, and despite multiple reminders, only 7 out of 21 of them did this. In parallel, I was able to pull information directly from the strip assistant. And this quantitative information was analyzed descriptively. In parallel, we did semi-structured qualitative interviews with GPs in the intervention group. All of them were invited to participate, and 8 of them agreed. And the qualitative data was analyzed through thematic analysis. On this slide, again, you can see how the strip assistant looked like, and I highlighted the left-hand side, which contained the information on diagnosis, and the medications on the right-hand side, and you can see that the drag-drop function was already used. And overall, we found that the drag-drop function, which was a part of the medication review intervention, was used for 83 of the participants in the intervention group. It could have been a bit higher if the GPs went to reset the tool, but we don't expect that a lot of them did this. So we expect that for 4 and 5 patients in our intervention group, the drag drop function was used. We also found that the prescribing recommendations were generated for the majority of participants. On average, there were 3.7 stop-start recommendations generated per patient. And for almost 60% of patients in the intervention group, it was reported that at least one prescribing recommendation was implemented. And on average, one recommendation was implemented per patient in the intervention group. Our findings show that overall, the GPs found the strip assistant useful and acceptable. They appreciated its ability to generate recommendations using large amounts of patient information. But the qualitative interviews also revealed several challenges regarding the implementation of the strip assistant, which can help us explain the relatively low implementation rate of the recommendations. So there were issues with the data imports from the EHR database that led to the fact that quite a lot of GPs had to manually enter data, update data, which they didn't like. This also led to the fact that overall, the preparation of the strip assistant was very time-consuming. And several GPs also reported functional issues. So for example, some of them reported that they were unable to export the PDF file with all the recommendations. A couple of quotes that support these themes are one GP saying, "I was a little overwhelmed by the administrative burden." Another one put it as, "If time expenditure remains that high, the strip assistant has no chance of being used in clinical practice." And another one said, "The strip assistant is actually very useful, even in the way in which it works right now, but it is too complex for everyday use." Other themes that we found in the qualitative analysis were the perceived unsuitability of recommendations. So some GPs were not happy with the type of recommendations that were generated because they thought that they were not relevant for their patients. And also in general, many GPs believed that the medication use of their patients was beneficial and there was not really a need to do anything about it. But on the other hand, other GPs reported that the tool helped them to be more aware of prescribing problems. So I found that really interesting. One GP said, I was happy that my prescribing was not questioned in general. Otherwise, I would have had to doubt the quality of my work. And one additional quote that I wanted to present, which I found really interesting in light of the digital tools that are more frequently used across healthcare system all over the globe, is you should radiate a certain competence and not give the impression, I need a computer to help me treat you. So some GPs also seem to be a bit more cautious when it came to how they talk to their patients after doing a medication review supported by a digital tool. Let's move to the final part of this presentation and talk about the cost-effectiveness analysis that we conducted alongside the trial. The approach to the cost-effectiveness analysis was based on the approach to the cost-effectiveness analysis of the OPRAM trial. So this means that the data for the calculation of the quality-adjusted life years, the QALYs, and the health services use was collected during the trial. We observed a 12-month period. We analyzed both a healthcare and a societal perspective. And in the healthcare perspective, we calculated the costs of different types of health services use. I'll come back to that in a bit. And in the societal perspective, we added the cost of informal care provided by informal caregivers under their retirement age. We also used multiple imputation methods. And to analyze the data, we used generalized structural equation models to simultaneously estimate incremental healthcare costs and QALYs. Looking at the comparison of quality-adjusted life years between both study groups over the one-year follow-up period, we see that they were slightly higher in the intervention group compared to the control group. Looking at the healthcare costs between both groups, we see that for both the healthcare system perspective and the societal perspective, healthcare costs were slightly higher in the control group than in the intervention group. The healthcare system perspective included costs from GP visits, specialist visits, emergency room visits, hospitalizations, nursing home stay, home care visits, meals on wheels, home help visits, rehabilitation, physiotherapy visits, and other types of therapy provided to a healthcare provider. And as I already said, the societal perspective included indirect costs of informal care provided by persons aged younger than 65 years of age. You can see that some of the costs were higher in the control group. These would be the bars to the left of the figure, such as hospitalizations and nursing visits at home, whereas other costs were higher in the intervention group, such as nursing home stays and medications. The bar at the bottom of the figure, the medication review, estimates the cost of the conduct of the medication review intervention. We found that the intervention resulted in cost savings of around 1,800 Swiss francs per patient and a gain of quality-adjusted life years over the 12 months observation period. I would like to point out that, in principle, the OPTICA medication review intervention was a single time point intervention. We don't have evidence that GPs went back into the tool and used it multiple times, which may also explain its limited effect. We cannot rule out the Hawthorne effect in the control group, which may have biased the results towards null. The medication discussion, in line with usual care, was added due to a requirement from the Swiss regulatory authorities, Swissmedic, the Swiss equivalent to the FDA, for example. And why we had to go through Swissmedic and not only the IRB was that the Strip Assistant was considered a medical device So it also needed to be approved by Swissmedic before we could start the trial. And they really insisted on us including this medication discussion in line with usual care instead of plain usual care, which was planned initially. Despite the fact that we collected information from different sources and different reminders, there was limited information on the implementation of the study intervention. And lastly, I would like to point out that the sample size was powered for the primary outcomes and not the health economic ones. Overall, we learned that the medication optimization intervention in OPTICA could be safely delivered to patients, but it did not improve medication appropriateness or reduce prescribing omissions. It resulted in only a fraction of prescribing recommendations being implemented, but we find evidence for cost savings and an improvement in quality adjusted life years in the intervention group. Some thoughts on what factors could potentially explain why we found cost savings and quality gains, despite the fact that we did not find evidence for an improvement in medication appropriateness or prescribing omissions. The Medication Appropriateness Index and the assessment of underutilization, while being validated tools that are frequently used in the literature, they may not capture all relevant aspects of medication optimization that could lead to cost savings and quality improvements. I think this leads us back to the question of what the most appropriate outcomes in medication optimization deprescribing trials are. Subtle changes in medication regimens that did not significantly impact the overall medication appropriateness could have reduced costs. For example, switching to less expensive generic alternatives or adjusting the dosages of medications. The medication review intervention could have led to fewer adverse events. I think since we saw fewer unplanned hospitalizations at 6 months, for example, that maybe points in that direction. And overall, also in line with the qualitative findings, the intervention could have likely led to an increase in GPs' awareness to monitor for medication-related problems. Thanks to the pragmatic data collection, few patients were lost to follow-up, and this was helpful in the analysis of the trial. Despite this, there were numerous challenges with the data exports, and I already mentioned the missing data. We had to go back to some of the participating GPs and retrospectively collect some information. And there was no way around using multiple imputation methods in the analysis. The qualitative findings helped explain the low implementation rate of the prescribing recommendations, and there are some thoughts that I would like to share about how I see digital medication optimization interventions and what we maybe should look for in the future to make sure that these tools work more efficiently. So GPs reported that not all the recommendations generated by the tool were suitable for their patients. And this was maybe linked to the fact that the tool used structured data from their EHR. But I guess there's a lot more in medical information that was not able to be fed into the tool and that couldn't be used. So maybe a recommendation that popped up had already been tried in the past and didn't work. And GPs didn't really like the fact because they felt that the recommendations didn't really reflect the needs of their patients. A big shortcoming that I saw was the lack of integration of the tool within the existing practice information system. The Strip Assistant was a web-based tool, and it was not integrated in electronic health records software programs. And if it had been integrated, that could have been helpful. I don't know how it is in all your countries, but in Switzerland, there's a lot of different electronic health record software programs. And they're also slightly different in the different language regions. So if we wanted a tool that was implemented across more than one of those software programs, that could be pretty complicated because at the moment, there lacks a standard for the interoperability of these software programs. I hope that things will improve in the future with this regard. Despite the EHR data imports, Manual data entry was still needed, which also wasn't really liked by general practitioners. Some of it was due to the fact that sometimes there was a bit of a lag between the data export, the import into the tool, and the time when the GPs then conducted the medication review. So that also explains why they had to double check everything before running the analysis. And of course, as a consequence of this and the fact that the time constraints in clinical care are pretty big, it wasn't really feasible. Some of them really spent quite a lot of time preparing and running the analysis, which would not be a sustainable solution. And also, one could hypothesize that the tool wasn't really tailored to GPs' needs. So thinking about digital to electronic support systems, other digital tools supporting medication optimization in the future, I think that is something really important to consider. Another lesson learned from the OPTICA trial was that we were able to recruit a generalizable study population thanks to minimal exclusion criteria. In a sub-study that I didn't have time to talk about today, we compared the baseline characteristics of our study sample with all the other older multimorbid patients of the 43 GPs in our study, and also with all the other multimorbid patients with polypharmacy across the FHIR database, meaning patients treated by other GPs who were not part of our study. And we found that they were really pretty similar. You can see some differences in terms of the sex distribution, but with regards to chronic conditions, lab values, vital data, they were really similar. Interestingly, the patients who made it into the study, they had a higher number of consultations, for example, than the other patients in all of the FHIR database. And I guess that could also explain if you see your provider more often, he or she has more opportunities to recruit you for the study. So I think this is very plausible in light of how we recruited patients for the study. Patients who participated in the OPTICA trial reported a high level of willingness to stop one or more of their medications. For example, 75% of them agreed with the statement, "If my doctor said it was possible, I would be willing to stop one or more of my regular medicines," from the RPATD. In a different sub-study, we looked at the association between the hypothetical willingness to deprescribe and the implementation of deprescribing recommendations. So that would have been the stop recommendations in the trial, and we did not find an association. Before I come to the end of my presentation, I would like to thank the entire OPTICA study team. All of this would not have been possible without an amazing team and without the participants, the GPs, and the patients. I would like to thank Sven Streit, the co-applicants, and also the other project partners for all their support. With this, I come to the end of my presentation, and I'm happy to take your questions now. Thank you so much for your attention.
Thanks very much, Katharina. Thanks for a fantastic presentation and giving us lots of insights from the OPTICA trial and the further studies that you've described as well. So yeah, now it's time to dive into the Q&A portion of the Journal Club session. So kind reminder to please enter your questions in the chat, or feel free to raise your hand if you would like to share a thought or question verbally. I know we have a couple of comments and questions coming in already, but I might take Chair's prerogative and maybe ask a question myself. First of all, Katharina, if that's okay. You mentioned obviously the medication appropriateness index as one of the kind of two major validated measures that you used. How challenging was it to assess the MAI for every chronic medication? I know you mentioned the kind of missing data issue, but I suppose even was all the nuanced information that you might have required to make an implicit judgment on each patient available, in general, even where there wasn't that export issue?
In general, it was pretty challenging to use the medication appropriateness index because it was very time consuming. My colleagues did it, who are blinded and who did the study assessment, did a tremendous effort doing this over many months. like the original version of the medication appropriateness index has 10 criteria, and we had to exclude one of them, the cost criterion, because we would just simply not have had that information as part of the assessments. And I think, as you alluded to in your question, it was rather challenging to do the EHR, to do the assessment based on the information we had from the EHR, because of course it would have been very beneficial if we had more information. So we developed standardized protocols, did inter-rater reliability assessments, and so on. But I think at the time of the study protocol writing, it was probably underestimated how time-consuming and challenging it was going to be to do the assessment based on the information from the EHR.
Fantastic, Katharina. So I'm just seeing we have a few questions coming through here. So a question from Joanna Trimble. Did the GP's medication records contain only the GP's prescriptions or the prescribing of other providers, e.g. specialists as well?
Thank you so much for this question. I think that would probably really depend on how the individual GPs handled their electronic health records. I think some of them add the information from after discharge or from specialists when the patients give them that information. Others don't. In Switzerland, we have a very fragmented healthcare systems, and shared electronic medication plans are only a very recent development. So I think that would help and make sure that the information about any medication prescribed by any type of provider would be there. But I think here, my hunch is that it probably really varied across the participating practices.
We have a couple of more comments in the chat, or messages in the chat from firstly Christopher Rocher talking about their experience in British Columbia in Canada around meaningful medication reviews and polypharmacy risk reduction. So if there's a particular question, but Katharina, let's see, is there anything to take from that there? And then I see from Kira Kirk agreeing similarly in Ireland around capacity and resourcing for these kind of reviews to happen in practice. I suppose, Katharina, any reflections maybe on, in spite of the results of OPTICA, any thoughts on, I suppose, ways that implementation of something like this in terms of comprehensive medication review in clinical practice in primary care might be supported or enabled?
I have a couple of thoughts. So first of all, I saw the role of pharmacists being mentioned, and I did not talk about this because in the OPTICA trial, and I think that retrospectively was also a big shortcoming, is that there was no pharmacist involvement as part of the intervention. In Switzerland, patients can go to any pharmacy for every single prescription, which would make it really challenging to involve them, and they have limited prescribing abilities for now. But I agree, moving forward, we really have to think about how to increase interprofessional collaboration in Swiss primary care settings for successful medication optimization intervention. So I saw that several of you mentioned the pharmacist role, and also about the implementation of tools overall. I think we really have to think about how to design these tools and how to integrate them into workflows so that they work as smartly as possible without adding an additional burden to the providers.
I see another question here, Katharina, from Darren Walsh. Why were chronic medications only used? Was it capacity? Evidence from older adults with cancer shows poorer outcomes affected by accounting for OTC and as required medications in multivariate analysis. Great study. Thank you for presenting.
Thank you for this question. Yeah, really, really good question. And we had a lot of discussions about this during the trial. I think part of it was capacity, and also the argument that we would look at chronic medication use by patients, but I totally agree with you. I think we could have also included any type of medication and calculated the medication appropriateness index over that. But if I'm not mistaken, it was specified in the study protocol that it would be looking at chronic medication. So I think that's also what then helped us make the decision.
Just a comment come in from Joanna Trimble here. So in our rural community in British Columbia, we are setting up a local primary care network with team-based care. It includes a clinical pharmacist to do med reviews in the community, but GPs are not referring. I think perhaps they don't like their prescribing second-guessed by a pharmacist. Investigating how patients can self-refer. Our local caregiver support group, for example, is interested in med reviews for those they care for, but can't get appointments with their scarce rural doctors in order to ask for a referral. Dilemma.
Yeah, that
Excellent.
is a real dilemma. I was just thinking about some work we did in the Swiss context, doing a survey with pharmacists, asking them about how they would like to collaborate with general practitioners on like medication optimization, and they were really willing. Unfortunately, we haven't done the same with Swiss GPs yet, but looking at the literature internationally, I think GPs are much more reluctant to do this. And in Switzerland, it's always a bit of a tension between pharmacists and GPs because in some of our regions, general practitioners are allowed to sell medications in their practices. So as you can imagine, this doesn't really help the interprofessional collaboration. And also the fragmented healthcare system and the fact that pharmacists in the Swiss context, they hardly see any information. They only see the prescription that a patient comes in, but they have no access. So it's also really hard for them to conduct a medication review because they really know like very little about the patients that are in front of them.
And are there any moves towards, I suppose, expanding access to information for pharmacists in community settings?
As elsewhere, I think digitalization is changing quite a lot. So there have been some developments in the Swiss context, and we'll see where those go. But one of the developments was, for example, the introduction of an electronic shared medication plan, which is a QR code readable by any healthcare provider and can be modified. And then, everyone should have access to the same information. So I think that can maybe help the problem that it was hinted at in one of the questions earlier about do you have information about what is prescribed by someone else? I don't think this fixes the problem of like information on diagnosis and any other relevant health information. With that regard, there has been a push to introduce an electronic patient record in Switzerland, which means that patients have to opt in, set up their account, and give their healthcare providers access. So it is not just simply set up for anyone, but it really requires like the patients to know about it first, which we saw that they don't really know about it yet in a recent survey. So I think if that is implemented across a larger scale, that could really help because then in principle, all the healthcare providers should have access to kind of everything patients want them to have access to. But it's still work in progress, if I can put it like that.
Positive developments, it sounds like. Another question from myself. You mentioned the finding about the differences in healthcare utilization at 6 months, but not at the 12-month time point. Do you have any reflections on, is this a true kind of maybe short-term impact on healthcare utilization that the intervention might have had?
Yeah, if we assume that the intervention had an effect on adverse events and therefore also fewer hospital admissions, for example, at 6 months, I think that could be one of the explanations. I think if we compare it to like the overall literature in which we see that after medication optimization trials, patients often stop, reduce, optimize, but then it's so dynamic and patients are back on pretty much all of their meds or even more later on. So there's no real sustainable effect. I think it's also plausible that this effect would then not be visible after 12 months.
Brilliant. I know other competing factors kind of overtaking the intervention effect maybe with time. Comment from Kira, following up on Joanna's point that this is interesting. Our clinical pharmacists joined the team in a few GP practices and largely found that patients through searching through notes. Being part of the team is a really different dynamic. We're sticking to that model for proposals for mainstreaming, even though they are part of the primary care network. If you think of clinical pharmacy in hospitals, no referrals are usually involved. The prescribers aren't aware that there are issues with prescribing until the pharmacist identifies them. lessons for potential implementation and mainstreaming there.
Super interesting. Makes me jealous, to see that there's pharmacists within the GP practice. I feel like that would probably solve a lot of the issues that we talk about in these journal clubs if there was more interprofessional collaboration overall.
Exactly. Can I ask, you mentioned one of the findings that was that GPs reflected that actually they were more aware of prescribing issues as a result of being involved in the study. Did you give any thought to maybe ways to evaluate a potential kind of wider impact of the intervention on maybe patients who didn't take part as part of the trial itself?
It's interesting that you ask because we're currently supervising a doctoral student at the University of Bern who is planning to look at this. The FIRE project database, they did some updates, which is why we still couldn't get the data. So there have been some delays, but the goal would be to look at whether there was a spillover effect on like the prescribing of the other patients treated by the physicians in the intervention group.
Very interesting. I'll keep an eye out for the results.
Stay tuned. I hope that we'll get the data soon. It has been a while, and I hope then the data will be ready to be shared with us soon.
Brilliant. We have a question in from Lelio Bib. Great study, thanks. Just wondered about the patient involvement in these reviews. Here in the UK, one of the important factors we found with having effective medication reviews, mainly pharmacy-led, particularly with polypharmacy, 10+ medicines, is aligning research evidence, such as this evidence-based tool, with what matters most to the patient at that time. And then through shared decision-making with the clinician judgment, agree what medicine changes should be made. A medicine's problem-generated list is likely to be overwhelming for clinicians in primary care. However, using it as a starting point as part of prioritizing what matters to the patient may help time demands to resolve problems that matter versus theoretical problems. Mm-hmm. So yeah, patient involvement, Katharina, in the OPTICA trial.
I think in the OPTICA trial, the intervention was mostly like provider focused. It involved the shared decision making, but that came later on. Personally, I totally agree with the comment. Patient engagement is key. I really wonder if that's the point we should start at and kind of meet patients where they are, and especially when there's issues with medication that you can kind of use as a starting point to discuss why medication optimization efforts are needed. But I think in OPTICA there, from that perspective, there was limited patient involvement, and I would also say that is like a limitation. In Switzerland, it is changing quite a bit now with like newer project grants requiring more active patient involvement. But I think this grant was given to the co-applicants in 2016-17. And I know that since then, the rules around that have changed. So I think nowadays we would have to think much more about how to involve patients in this type of research.
And I know some of the models that were discussed in the comments do kind of, how the patient fits into that medication review process, and whether it is starting with what matters to the patient and patient priorities as the starting point, and then I suppose moving into detecting issues. Just see another comment from Colleen Hicks. GPs say they are overwhelmed with info from pharmacies and government/insurance documentation for payment in Ontario, Canada. Perhaps in the future, some sort of central computer system listing all meds that the patient is on from every source that all healthcare providers can see needs to be developed. This list could then be computer monitored for drug interactions, medication appropriateness, etc.
That is a really interesting thought. I agree. I think we could probably say the exact same thing about Swiss primary care settings. In interviews with pharmacists, for example, they tell us that sometimes they try to call the GP practice, but usually they don't get through to the GP. So they have no idea if their message makes it to the physician. There's really a lack of communication channels, and I have really high hopes into this shared electronic medication plan that is rolled out in the Swiss healthcare setting. I think that's pretty much what you mentioned, like one source of information that should be updated and complete at all times, and that all healthcare providers treating the same patient have access to.
Let me just see, so a few more comments I think in there from Joanna, just saying the patients and especially their primary caregiver family member have to be included. So it's a point I think we can all agree on. Let me see, from Christopher, see, the health data coalition I mentioned is based upon the principle that GPs need to determine what measures they want to look at through a quality improvement approach. For example, how many people with type 2 diabetes do I have? What are the HbA1c results? How am I using meds per guidelines? Where can I improve? This has required systems support, but really comes through the GP organizations we are fortunate to have in BC, called Divisions of Family Practice. So what primary care communities of practice do you have in your area and what are their interests? Also, it's less about tools and med knowledge and more about interest and data availability as a start, and then support for changes. And yes, patient engagement is very important. Katharina, was a question there is what primary care communities of practice? Are there any such communities of practice in Switzerland and any focuses or interests they might have?
I'm not a clinician myself, so I feel like probably someone else could answer this question better than I can. But I'm thinking about the professional societies in the field of primary care. There's the National Association, Swiss College of Primary Care Physicians. Probably that's not the official English translation. Then there's the regional ones. We have a federalist country, so our healthcare system is very fragmented into 26 administrative units. So a lot of the cantons have their own primary care physician associations. I know that some of them are also trying to work more interprofessionally with like pharmacist associations. So I think there's a lot of hope there. And I'm also thinking about the bigger practice networks that are being established. So if we think back like 20, 30 years in Switzerland, most of the primary care practices would be independently run by one or two physicians. It's changing now that they're part of bigger practice networks who sometimes also, like you mentioned, implement guidelines that everyone should adhere to. So I think that's probably also one of the possibilities to intervene on.
Brilliant. I think we're just probably left with another couple of minutes for questions before we wrap up the session. Maybe if anyone has a last burning question for Katharina, if you want to either raise your hand or put it in the chat. Katharina, I might ask one last one for myself, if that's okay. If you were to give one piece of advice, either for someone doing, the next iteration of the OPTICA trial or modifying the intervention, or in a different setting, a similar medicines optimization trial, what maybe one piece of advice or one lesson would you kind of emphasize for anyone planning future work?
Oh, difficult to mention one. Maybe it has multiple aspects, but I think putting a lot of emphasis on intervention design and piloting interventions is crucial. I think our funding landscapes often don't really allow enough time to do this. But I think it's really, really important to work with all the different stakeholders and see that the intervention is designed in a way that it meets their needs and preferences so that we don't run into like problems that could be very easily avoided when we when we implement and run the trials.
Yeah, I think that's great piece of advice. And yeah, certainly I think lots of people will reflect and say, yeah, they've had experiences where they would agree on that. And I think that looks like all the questions we have. So Katharina, just to say thanks so much again for sharing your insights and your work with us here this afternoon. Yeah, really appreciate you taking the time.
Thank you so much for all your questions, comments, and the interesting discussion. If anyone has any additional questions, feel free to reach out, contact me on LinkedIn or by email. I'm happy to chat about this always. Thank you so much. Have a nice rest of your day.
Thanks, Katharina. So just to wrap up our session, just to thank everyone for joining. Just to flag the upcoming Journal Club session in December will be hosted by the US Deprescribing Research Network, a fantastic speaker, Dr. Michelle Keller. please visit deprescribingnetwork.ca/journal club to sign up, or you can scan the QR code on the slides here to bring you to this page. So before we finish up, we are hoping to get some feedback on this session. So we're now going to be launching a poll to try and understand, I suppose, whether the session met your needs or any suggestions that you might have. So you should hopefully be seeing a feedback survey appearing on your screen now with 3 questions on it. So might just give a few moments for you to hopefully respond to those questions. See responses coming in already. Just like to thank you for completing the survey, as it is very helpful for the organizers to continue to improve future sessions. As said, the Katharina is happy to take any further questions you might have. If you would like to share any suggestions for future Deprescribing Journal Club sessions or topics, please do write to the email address shown here, or get in touch with the Twitter and Facebook handles shown here. Let's see, we have most responses in for the feedback survey, but just I suppose as we finally wrap up on that, just want to thank everyone who's been involved in the organization of this session. The session wouldn't have been possible without the participation of the different groups, and thank you to each and every one of these members for their help. Thanks again to Katharina for a fantastic presentation, and lastly, just to say thanks very much to you for joining the session or watching it back afterwards. Wishing you all the best for your day, and see you again at the next session in December. Thanks very much.